Hello everybody, my name is Dr. Nabila Faridi. I am a PGY1 pharmacy resident at Xavier University of Louisiana College of Pharmacy. Today I will be talking to you about comprehensive lab values. As we go through the slides, I will highlight some of the key lab values that I would like you to commit to memory for your exam. Here are today's lecture objectives. We will focus on recognizing the normal ranges for common lab values in adults, identify common causes for abnormal values, interpret the clinical significance of abnormal lab values, utilize clinical laboratory data to monitor various disease states. Here is the outline for today's presentation. Some clinical pearls for interpreting lab data that I would like to highlight are: normal values may vary from lab to lab depending on techniques and reagents used. Values may vary depending on a patient's age, gender, weight, height, or other factors, and these reference values listed are institution specific. So be mindful when you are on rotations to reference your institution's normal ranges. Here on this slide, I have the basic metabolic panel, also known as the Chem7 and electrolytes. This is one of the slides I would like you to commit to memory, as these are the electrolytes that are commonly used when patients are admitted in the hospital or in the emergency department. In the basic metabolic panel, we have sodium, potassium, chloride, carbon dioxide, serum creatinine, blood urea nitrogen or BUN, and glucose fasting. We also measure a patient's magnesium and phosphorus. To the right of this slide, I have what is called a fishbone model. So sometimes you will see this fishbone model drawn out with a patient's current lab values, but it will not state if it's sodium, potassium, creatinine, or carbon dioxide. So it will be important to recognize which electrolyte goes where in this fishbone model. On this slide, we have the comprehensive metabolic panel. This is made of the basic metabolic panel, which was listed on the last slide, along with the following. We have calcium, albumin, alanine aminotransferase, aspartate aminotransferase, alkaline phosphate, total bilirubin, total protein, and uric acid. Again, on the right of the slide, I have a fishbone model of the comprehensive metabolic panel. I would like you to think about what organ functions do ALT and AST measure. On this slide, I have the arterial blood gases. Here we have the pH of the blood, partial pressure of carbon dioxide, partial pressure of oxygen, oxygen saturation of the blood, and bicarbonate. Next, we have the complete blood count, also known as the CBC. This is one of the slides and normal values that I would like you to commit to memory. Here we have the hemoglobin, which is a direct indicator of the oxygen carrying capacity of the blood, hematocrit, which describes the volume of blood that is occupied by red blood cells, white blood count, and platelets. On the right, we have the fishbone model, again, which indicates what the patient's current lab values are at that given time. On this slide, I have shown a compilation of all the fishbone models that are used. Fishbone models are commonly used for blood chemistries and electrolytes. Here we have the indices of red blood cells. These are often used when a diagnosis of anemia is being considered. The first one is red blood cells. They're also known as erythrocytes. Their lifespan is about 120 days. Next, we have the mean corpuscular volume, which is an estimate of the average volume of the erythrocytes. Next, we have mean corpuscular hemoglobin, or MCH, which can help differentiate between macrocytic anemia or microcytic anemia. Next, we have mean corpuscular hemoglobin concentration. This is a measure of average hemoglobin concentration in the red blood cells. And now remember, hemoglobin is the molecule that carries oxygen in our red blood cells. Lastly, we have reticulocytes. These are immature red blood cells that are formed in the bone marrow. An increase in reticulocytes usually indicates an increase in red blood cell production. Here we have the white blood cell differential. The white blood cell count represents the total number of white blood cells in a given volume of blood. Mature white blood cells exist in many forms, which include neutrophils, lymphocytes, monocytes, eosinophils, and basophils. A white blood a white blood cell count with differential provides a breakdown of the percentage of each type of white blood cell. The first one we have here on the slide is white blood cells. White blood cells are also known as leukocytes. An increase in white blood cell count is referred to as leukocytosis. Leukocytosis may be caused by infection, leukemia, trauma, a thyroid storm, and corticosteroid use. Emotion, stress, and seizures may also increase white blood cell count. A decrease in white blood cell count is referred to as leukopenia. Decreased white blood cells may be seen in viral infections, aplastic anemia, and in bone marrow depression caused by the use of chemotherapy or anticonvulsants. Next, I would like to highlight neutrophils. These are the most common type of white blood cells. Their primary function is to fight bacterial and fungal infections by phagocytosis of foreign particles. The two types of neutrophils are segs and bands. Bands are immature neutrophils. In clinical practice, sometimes you might hear a left shift or a right shift. So a shift to the left or left shift occurs when there is an increase in bands. This may occur during an infection or leukemia. An increase in circulating neutrophils is also called neutrophilia. Neutrophilia is associated with infections, metabolic disorders, uremia, response to stress, emotional disturbances, acute inflammation, and use of medications such as corticosteroids. A decrease in the number of circulating neutrophils is called neutropenia. Neutropenia may result from viral infections, septicemia, and the use of chemotherapy agents. Next, I would like to highlight lymphocytes. This is the second most common type of circulating white blood cells. They are important in the immune response to foreign antigens. An elevated lymphocyte count is called, you guessed it, lymphocytosis. Lymphocytosis may occur in hepatitis, chickenpox, herpes infections, or other viral infections. Some bacterial infections, such as syphilis or leukemia, multiple myeloma, are also associated with lymphocytosis. A decrease in lymphocyte is called lymphopenia. This may result from infections, burn trauma, HIV, or lymphomas. Next, I would like to highlight eosinophils. These are phagocytic white blood cells that assist in the killing of bacteria and yeast. Eosinophilia is associated with allergic disorders or parasitic infections. Basophils are present in small numbers in circulating blood. Now, you don't have to commit these to memories, but it's important to see the common trend that white blood cells are important in fighting off bacterial, viral, and fungal infections. So knowing the trend, if your neutrophils, your lymphocytes, your monocytes, or eosinophils are going up, what could possibly be happening, and vice versa. If the different types of white blood cell count is decreasing, what could that indicate? Here we have the urine analysis. The urine analysis looks at the appearance and color of the urine. So ideally we want the color to be clear to dark yellow and appearance to be again clear. If it's cloudy, that is not a good sign. We also look at specific gravity, pH, proteins in the urine, glucose in the urine, ketones, blood, bilirubin, leukocyte esterases, and nitrites in the urine. These are useful when we are diagnosing a patient with a urinary tract infection, if they have diabetes, and we're trying to see if they have so much blood glucose that their glucose is spilling into the urine, or if their kidney function is adequate, and if not, they might have some proteins in their urine, which, as the slide says, may be a marker of renal disease. Protein in the urine is sometimes referred to as proteinuria or specifically albuminuria, and albumin is a specific type of protein. Here I have a patient case for you to practice some of the things that we have talked about so far. You are rounding on an internal medicine API rotation with the ICU team. When preparing for rounds, you noticed that there was a new admission last night, an Olympic bicyclist who was struck by a car. The patient begins to spike a fever. The CBC, or the complete blood count, chest x-ray, urine analysis, and blood and urine cultures are done to look at possible sources of infection. The CBC and UA results are as follow. Begin reviewing the patient's laboratory data in preparation for rounds. Here are the patient's labs. Here are some questions I would like you to pause the slides and think about and answer and be able to discuss when we meet in lab. What are some abnormalities that are noted in the CBC? What is a left shift and what does it indicate? Is there a left shift present in this patient? What abnormalities are noted on the urine analysis? What is the most likely cause of these abnormalities? What follow-up actions or treatments will probably be needed as a result of these abnormal laboratory tests? Go ahead and pause this recording before we continue to the next slide. Next, we are going to talk about hematologic tests. As mentioned previously, with the indices of red blood cells, which are important in identifying anemia, hematologic tests are also used to determine what type of anemia may be present in a patient. So, the hematologic tests include iron, ferritin, total iron, binding capacity, vitamin B12, which is also known as cobalamin, and folate. So, starting from the top, iron measures the concentration of iron bound to the iron transport protein transferrin. Ferritin is the storage form of iron. TIBC, or total iron binding capacity, is an indirect measurement of the iron transport protein transferrin. Vitamin B12 is an important vitamin in the synthesis of DNA, neurologic function, and hematopoiesis. A deficiency in vitamin B12 can be causative of macrocytic anemia. Folate is also important in the synthesis of DNA. Deficiency of folic acid results in megaloblastic anemia. Continuing on with the different types of hematologic tests, next we have coagulopathy. Coagulopathy is a measurement to see how well or poorly the blood is clotting. Now remember, if the blood isn't clotting well, the patient is likely to bleed out. However, if the patient is overclotting, they are likely to throw a clot either in their extremities, in their lungs, in their brain, or in their heart. And these clots can be life-threatening. Some examples of coagulopathy are prothrombin time, activated partial thromboplastin time, and INR. INR value is one that I would like you to commit to memory. This is also a slide I would like you to commit to memory. Remember, INR is the international normalized ratio, which is used to determine the anticoagulation effect of warfarin. If the INR is too low, that means the blood is too thick, it is high risk of clotting, and if the INR is too high, the blood is too thin, and the patient is at risk for bleeding out. So we would like the warfarin therapy to result in an INR within a desired range. Here I have listed the different indications for INR goals. Commonly we'll see an INR goal of 2 to 3 for the conditions listed on the slide. In unique circumstances, we'll have an INR goal of 2.5 to 3.5. Now remember, with warfarin therapy, the INR can be increased or decreased with various factors such as inconsistent diet, alcohol intake, or drugs that interact with warfarin. Here we have the cardiac tests. These are useful for patients that have a possible myocardial infarct or they have heart failure. So here we have creatinine kinase, which is an enzyme that is found primarily in skeletal and cardiac muscle and in smaller fractions in the brain. Next we have CKMB. This is similar to CK, however, this is specific to cardiac tissue and does not appear in the brain. So the levels of this enzyme will begin to rise 4 to 8 hours after a patient has had an MI. So getting the baseline CKMB levels and continuing to monitor if a patient presents for a potential MI would be useful. We also have troponin 1 and troponin T. These are also enzymes that are found in the cardiac muscles. BNP, or brain natriuretic peptide, is increased from the heart or released from the heart in response to increased workload. And CRP, C-reactive protein, this is produced in the liver and can aid in the diagnosis of inflammatory conditions such as rheumatoid arthritis or infections. This can also be a useful indicator for risk of heart disease. BNP and CRP are commonly assessed in patients that have heart failure. Here we have a lipid panel. This is one I would like you to commit to memory for lab and for your exam. Here we have total cholesterol, triglycerides, high density lipoproteins, and low density lipoproteins. As you think about the lipid panel, I would like you to think about the four statin benefit groups and be able to discuss them during lab. I'm sorry. Free T4 is a diagnostic test that may be used to confirm the diagnosis of hypothyroidism, which is decreased free T4, or hyperthyroidism, which is increased free T4. Lastly, we have total triiodothyronine. T3 is not the predominant circulating thyroid hormone. T3 is 3 to 4 times more potent than T4. Now, to summarize, hypo and hyperthyroidism are determined by TSH levels in free thyroxine. So in hypothyroidism, we will see high levels of TSH and low levels of T4. In hyperthyroidism, we will see low levels of TSH and high levels of free T4. This is one I would like you to commit to memory as well. For diabetes, we have a measure of hemoglobin A1C. This measures the percentage of the hemoglobin A molecule that is glycosylated or bound to glucose. Here I have listed the reference range. For the adrenal gland, we have measures of cortisol, which is a hormone produced by the adrenal cortex. It plays a critical role in carbohydrate metabolism in response to stress. So during midterms and finals, when you're studying all through the day, all through the night, your cortisol levels are likely to be elevated. And we see that the reference range varies between morning and night. Next, for the adrenal gland, we have the adrenocorticotropic hormone. This is a hormone that is secreted from the anterior pituitary. It controls the release of cortisol from the adrenal gland. ACTH may be associated with Cushing's disease, adrenal hyperplasia, Addison disease, and we might see a decrease in ACTH in adrenal malignancies or states of pituitary insufficiency. Here we have measures of the gastrointestinal tract. Here we see ammonia, total bilirubin, gamma-glutamyl transpeptidase, which is a measure to see alcoholic liver disease or functions of the pancreas. We also have lactate dehydrogenase. This is an enzyme that is involved in the interconversion of lactate and pyruvate. It's found in many tissues, including the heart, brain, liver, skeletal muscle, kidneys, lungs, and red blood cells. An elevated LDH is not a very specific finding, as it may occur due to damage in many of the different tissues that we discussed. Next, we have amylase, which is an enzyme that aids in the digestion by breaking down complex carbohydrates into simple sugars. The majority of the amylase is produced in the pancreas and salivary glands. The amylase levels begin to rise 2 to 6 hours after the onset of acute pancreatitis. So amylase is a good measure to see if the patient is having inflammation of the pancreas. Lastly, we have lipase. This is also an enzyme that aids in digestion of fats. It is also primarily secreted by the pancreas. Lipase is also useful in the diagnosis of pancreatitis and is considered a more specific marker of pancreatitis than amylase. That is important. Like amylase, the lipase levels begin to rise within 2 to 6 hours of onset of acute pancreatitis. If the lipase is normal, however, the amylase is elevated, this suggests a non-pancreatic origin of the increased amylase. So that is an important differential diagnosis tool to see if a patient is having these abnormal lab values, if it is truly from a pancreatic cause or non-pancreatic origin. We are now at the end of the lecture. This is the reference I used. If you all have any questions, please feel free to email me prior to lab or after lab. I look forward to seeing you all during lab.